Well, why don't we get started? Welcome, everybody. My name is Randy Wong. Thank you very much for joining us. Tonight, we are going to have our May monthly webinar on the treatment of floaters. Tonight, I'd specifically like to talk about what is vitrectomy. There's always confusion about what is vitrectomy versus FOV, and the short answer for tonight is that vitrectomy and FOV are synonyms. They're absolutely the same. Think of vitrectomy as a name for the clinical name for the operation, and FOV would be kind of the layman's terms for what a vitrectomy is. Remember that I'm a retina specialist. I live in Fairfax, Virginia. I practice in Fairfax, Virginia. I actually live in Bethesda, Maryland. Both are about 20 minutes from Washington, D.C. So your destination to come visit will be either Northern Virginia or Washington, D.C. We have three airports: Baltimore, Washington, BWI, Dulles, and Ronald Reagan, which used to be, it's Ronald Reagan. I have two websites, vitrectomyforfloaters.com and retinaeyedoctor.com. This webinar is for informational purposes only. This webinar does not offer medical advice, and nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may quickly become outdated, especially due to the rapid nature or the nature in which the topics are covered, which are constantly evolving rapidly. The materials and information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or retinaeyedoctor.com or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, you are not creating a doctor-patient relationship. Although I am a doctor, I am not your doctor until and unless there is a written agreement specifically providing for a doctor-patient relationship. Okay, now that we've got that out of the way, tonight, what I want to talk about is address that vitrectomy, FOV, and floater-only vitrectomy are synonyms. They're all the same. It's the exact same technical operation. Doctors call it vitrectomy. Those of you suffering from floaters have known it as an FOV or floater-only vitrectomy. I'd like to show you a couple of slides to go over other indications or reasons to perform a vitrectomy, and then we'll follow up with questions and answers. And I'd like to be done in about 25 minutes. These are some of the more common reasons that I might perform a vitrectomy: macular holes, retinal detachments, epiretinal membranes, vitreous hemorrhage, and there's others. And then at the bottom are floaters. So these are all reasons why I, as a retina specialist, need to perform a vitrectomy: to repair macular holes, to repair retinal detachment, to remove epiretinal membranes, to remove blood or vitreous hemorrhage, or to remove vitreous opacities. This is a macular hole. The macula is the functional center of the retina. It allows us to see 20/20. It gives us our best color perception. And as you can see in this illustration, there is a hole right in the center of the macula. It causes decreased vision and distortion. For me to fix this macular hole, I need to work on the macula. I need to put my instruments right around this area. So for me to do this safely, I must first perform a vitrectomy or an FOV. So the first part of the operation that I do for almost all these different cases, macular hole, retinal detachment, etc., is I need to perform a vitrectomy. And in patients like you who are suffering from floaters, that's the only part of the operation that I need to do. So in essence, a floater-only vitrectomy is basically the simplest procedure that I need to perform. Retinal detachments are a common reason to perform vitrectomy. Here you can see that there are tears in the peripheral retina, and the peripheral retina is that kind of lifesaver shaped gray donut that you see. And if you look through that gray where the two arrows are, those are holes which have let fluid underneath the retina, and the retina detaches. But to repair a retinal detachment, one of the more common ways to do so is to perform a vitrectomy. So I'll perform a vitrectomy first, and then I can work on the retina. I think you get the idea. Here's another illustration of a retinal detachment. There is a retinal tear. You can see the areas that's detached, it's whiter. And you can see the vitreous, which is clearer. Another reason I need to perform a vitrectomy is for an epiretinal membrane. This is a membrane or a thin layer of tissue that grows on the surface of the retina, and it covers the macula. And the macula, again, is the functional center of the retina. It gives us 20/20 vision, etc. Now, the membrane can cause distortion or decreased vision. So a lot of times I need to remove the membrane off the surface of the retina. But for me to be able to do that safely, I need to first perform a vitrectomy. This is an illustration where I have already done the vitrectomy, and with that instrument on the left, I'm actually grabbing an epiretinal membrane and peeling it off the surface of the retina. So you can see why you want the vitreous out of the way so you can safely operate on the retina. Here's a complete retinal detachment, and I'm doing a vitrectomy as the first part of the repair of the complete retinal detachment. This could possibly be at the end of a vitrectomy. I see a retinal tear or a retinal hole, so I am putting laser burns in that circular area in the location of the retinal hole or the retinal tear. In cases of advanced diabetic retinopathy called proliferative diabetic retinopathy, abnormal blood vessels can grow on the surface of the retina. And as shown here, the abnormal blood vessels can spontaneously bleed, and you get blood in the vitreous, called a vitreous hemorrhage. This can cause decreased vision. And for me to remove the blood and to work on the retina, guess what? I need to perform a vitrectomy. Here's a posterior vitreous detachment, otherwise known as a PVD. You can see the area of the detached vitreous, and there are the floaters. And this is a common reason I would perform a vitrectomy, to remove the vitreous opacities or the floaters. And this is your typical scenario for an FOV. So those are some common reasons or diseases or situations in which I'm going to perform a vitrectomy, which is the same operation I would do to perform an FOV. If you'd like to, that's really all I have to say tonight. I'd like to open up the webinar to questions that you might have. Go ahead and type them in the chat bar. I'll read them and answer them as best I can. I think Brad had the first question, and his question is, do you leave any vitreous behind the lens? As I am told that it prolongs the health of the lens longer. As someone with a perfectly clear lens right now, I would like to keep it that way as long as possible. And Brad, I understand that, and I understand that there's lots of stuff you read or hear. One of the issues with cataract formation, which is natural clouding of the lens, is that we don't really understand why it occurs in some patients after vitrectomy versus others. I can tell you it's been my experience in my practice over the last 25 years that cataracts generally do not occur after vitrectomy. They certainly generally do not occur in vitrectomy for just floaters. Cataracts are more likely to occur in cases where I need to use intraocular gas in cases of macular hole or retinal detachment. But that's not why we're here tonight. We don't use gas, or I don't use gas in situations for just removing vitreous opacities. The theory that leaving vitreous along the back of the lens prevents cataract formation is just that. It's a theory. This is a theory on how cataracts may develop after vitrectomy. I would also propose that it's possible that cataracts can form after or cataracts develop with relation to the length of the operation. My point is that we don't really know. So you have to take a lot of this with a grain of salt. It's never really been studied. And this is just someone's explanation or theory as to how we might prevent cataract formation. I hope that answered your questions. Are there any other questions? Charles asks, historical data analytics of 100% success of FOV timeline. Charles, could you ask that question in a different way? Because I don't really understand what you're asking. And I apologize for that. In the meantime, anybody else have anything to say? I don't mean to put you on the spot, Charles. I just don't even know how to start. Okay. So Charles says what he means is complete removal of floaters and for how long? That's a tough question. And I would say that if you were to become my patient, and if one of the things we talk about are your expectations from surgery. My goal for surgery would be to significantly reduce the number of opacities or floaters that are bothering you. It wouldn't be smart for me to guarantee I can absolutely remove all of them. I think you can expect, it might be reasonable to expect that having a vitrectomy can remove most of the floaters, and that generally does happen. I would say most of the time, all of them are removed. But since I can't see exactly what you're seeing, it's impossible to say, and it would be kind of ridiculous for me to guarantee that I could remove all of them. Your expectations should be to significantly reduce the number of floaters that are bothering you without causing damage. We can always go back. I would say that if the floaters are related to opacities in the vitreous, then once they're gone, they're gone. Now, there can be other reasons in the future why floaters may come back, but not for floaters that are located in the vitreous, which is the majority of the cases. Now, if you read some of my articles online, other causes of floaters could be from bleeding or from inflammation. Those are generally not present in healthy eyes. So most of the time, we're limiting our discussion to removal of floaters related to the vitreous. And if we're removing the vitreous, you can expect this to be basically a lifelong removal. Brad says, has my stance changed on inducing a PVD in younger people changed? Brad, what do you believe my stance to be? My stance right now is, especially in young, I would encourage or heavily recommend inducing a PVD. Now, you may have listened to some earlier, either earlier video or earlier webinar where I talked about it may not be necessary. And with regard to the floaters, it's really not necessary to remove to induce a PVD. But as I've learned, inducing a PVD makes the operation more efficient, and it significantly reduces the chance of developing frill, which it seems to be limited to the younger population. Charles wants to know how much vitreous remains after FOV. I have no idea. I'm going to guess somewhere around 80 to 90%. The vitreous, which is very anterior and to the sides of the lens, really is very difficult to remove. And you generally aren't able to see that vitreous. So without, again, I want to help you without causing any damage. So trying to get after that vitreous is kind of a waste of time. So I will try to get as much vitreous in the front and off to the sides as possible without causing you any damage. It's a good question, though. And the reason I don't know is I have no idea how to measure it. Do you use, Brad asked, do you still use blue or green dye, and why do you sometimes use them and sometimes not? In patients with a PVD, where I can more easily see the vitreous opacities, the dye is not necessary. Probably over the last few years, I've switched to using Kenalog, which is kind of a grainier substance. It floats around better. And I think most days I just inject Kenalog, which mixes better with the vitreous and makes it easier for me to see the Kenalog. It's also easier to remove. It's half dozen. It's 6 or half dozen of the other. It just doesn't really matter. The dye does a good job, but I think the Kenalog does a better job. And if you look on YouTube, you can see the videos that I have where you're inducing a PVD. I think it's much easier to see with the Kenalog. How many FOVs have I performed? I don't know, because I don't keep track of all the different reasons I perform a vitrectomy. If you take all the vitrectomies I've performed, it's in the order of tens of thousands over 25 years. So it's been a lot. But I don't, for instance, I don't know how many retinal detachments I've ever treated. I don't know how many epiretinal membranes I've ever treated. It's a statistic that I've just never bothered tracking, and I apologize for that. But if you think of it this way, if that 99% of what I do is a vitrectomy for something, then I've done a lot of vitrectomies. Chrissy, do you want to step in and say anything?
Sure, just a couple things, Randy. Hi, everyone. Thanks for coming tonight. My name's Chrissy. I know I've spoken with a couple of you before. Just wanted to say I'm definitely here to help. If you guys have any of those basic logistical questions, things about insurance, things about, scheduling, things like that, just reach out to me. You can definitely email me. My contact information is on the website. It's on one of these slides right there, too. Definitely email me. You can call me. I do have a Google Voice, but I'm a little hard to get on the phone. So the best way to reach out to me is in cyberspace. So if you just email me, I'll do my best to assist you. And just a note, a lot of people think that FOV is not covered by insurance, that it's somehow an elective procedure, and that's actually not the case. It is medically necessary, and most insurances do cover it. It's just a matter of, local versus if you're coming from out of state. But email me and let me know what kind of insurance you have, and I can guide you the best way I can. But definitely might be covered by your insurance, so definitely don't count that out. I can still give you self-pay pricing, but usually insurance covers it. So, and then lastly, one more thing to note, it's a very common thing that people don't realize, but if you're traveling to come and see us, try to bring someone with you. We understand you can't always do that, but it's better because, for anesthesia and restrictions on taxis and things like that, the surgery centers kind of, they have rules. So if you can bring someone with you, great. I'm in the process right now of trying to contact some hotels around the surgical center to see about van service. I'll have that information in a day or two. But again, just if you can bring someone with you, that's always best. So, and that's about it.
Well, everybody, thank you very much for attending. I think we're going to end it early tonight. Look for us next month. If you just signed on, I apologize that we got most of this out of the way already. This has been recorded. At some point, I'll be able to get this on YouTube. If anyone has any last questions, go ahead and ask. Otherwise, we'll see you next month. Look for us on Facebook or on the website to determine to get the registration link. Charles wants to know, is the percent of a tear or detachment stay about 1%? Yeah, I think probably it's limited to about 1 to 2%. 2% being those patients in whom I need to induce a PVD. 1% in patients who've already had a PVD. Brad, thank you for attending. Thank you for thanking me. Jose asks, is lattice degeneration related to floaters, or is it vice versa? I don't think either one are related. Both are. Lattice degeneration is described as a natural thinning of the retina. We see it in about 8 to 10% of the normal population. lattice degeneration is commonly associated with retinal detachment, but not floaters. Floaters are commonly seen after a PVD. A PVD can cause a tear and a retinal detachment, but floaters and lattice degeneration are not necessarily associated. As I just said, lattice degeneration is normal, and it's found in about 8 to 10% of the population. Charles, you're welcome. Thank you for thanking me. Well, everyone, thank you very much for attending. Chrissy, I'll speak to you tonight or tomorrow. Thank you for your time and helping us out. And to everyone else, thanks for attending. We'll see you next month. Have a great evening. Talk soon. Bye-bye.